Thank you. So, monitoring alveolar recruitment by lung volumes. These are my conflict of interest. And these are the relevant lung volume we will talk about. We have the classical functional residual capacity, which is the lung volume at lung rest, 0 PEEP. Okay. Then we apply PEEP, and we have the lung volume due to the application of PEEP, and we have tidal volume. Generally, we call end expiratory lung volume the sum of the functional residual capacity and the PEEP volume. These are the volumes we will talk about. There are many techniques to measure lung volumes. I will just talk about dilution techniques because other speakers will talk about imaging. Basically, we have two different ways to measure lung volume with dilution techniques, which is closed circuit and open circuit. In the closed dilution technique, in the closed one, basically we have a bag with a known volume, a known fraction of a gas, generally helium. We connect that to the patient at some point, and the lung volume we will measure is exactly the volume in the moment of connection. We will dilute, and we will have the final gas concentration. We need a machine to measure the gas concentration. To apply that on patients on mechanical ventilation, we did some change in the circuit with a clampable tube, okay? And we can decide to make the measurement in any moment, like a zip or a PEEP. We show a good correlation with CT scan, and other groups did the same technique, but in a way that does not require to disconnect the patient from the ventilator, okay? But it works, basically. Many advantages, but one disadvantage, which is that you need a machine to measure the tracer gas, helium, for example, and it's not so easy, but it's feasible. What about open dilution techniques? Open dilution techniques are much better from the mechanical point of view because you can have a ventilator to do that. The principle is not very different. You have some tracer. You can use oxygen. You can use nitrogen. You know how much you give. You measure how much you have out. The difference depends on the consumption for oxygen or 0 for nitrogen, which is not consumed. You make a change on the ventilator. You change the fraction of oxygen from 70 to 50 or to 40, and you follow over time waiting for equilibrium. At the end, you will, from the how much tracer you have put or removed to reach the new equilibrium, will give you the, divided the difference in concentration, will give you the volume you are measuring. The technology you need, the ventilator or the system needs is not so easy, okay? Especially you need a very precise synchronization between the gas measurement and the flow measurement, because the mass you will compute is the multiplication between the two. There are many systems around. There were many systems around. I will just tell you about this one because it's the only one that has been applied on a ventilator, which is a modified technique. The tracer is nitrogen, but is not measured directly. It's derived by the oxygen and the CO2. This has been, I will not go, you have understood it, how it works, okay? You need just to make a change on the ventilator on a fraction of oxygen. Is enough 10%, but it's better a bigger change, okay, like 20%. And this is has been applied in a ventilator, okay? In the old version, in the new version, this is the only one ventilator I know that is able to measure, to give this measurement at the bedside. It has been studied by Italian group, also French group, okay? It seems that it works with acceptable clinical, sure, from a clinical point of view is acceptable error. From experimental point of view, that's a different story, but it works. So, and before to go to how to measure alveolar recruitment, let me try to remind some concept that is relevant to interpret what we measure, okay? We measure a volume, but we don't know what behind that volume, okay? You can have an increase in volume because you increase the number of alveoli, but you can have the same increase in volume just because you distend the alveoli. You measure the volume, you don't know why. The same, depending on the patient, you will have a different volume increase with the different, changing the pressure. Even without changing the number of alveoli, two patients with different chest wall compliance will have a different lung volume change with the same pressure change. That's why, okay, we see different end expiratory lung volume in different conditions. In this work by Becker, different patient, normal, primary RDS, secondary RDS, different PEEP level. Of course, decreasing the PEEP, lower end expiratory lung volume. More sick the patient, lower end expiratory lung volume. And why? These are, I put together several studies that have measured end expiratory lung volume with different techniques, okay? Just to show you which is the end expiratory lung volume you can expect in a RDS patient. This is the PEEP levels used in the study, okay? And in green, the moderate RDS, in the yellow, the severe. Okay? And you see that we have an end expiratory lung volume between 1,000 and 1,500. Why the end expiratory lung volume is decreased in RDS patients? Well, because inflammatory infiltration, because alveolar collapse, because chest wall impairment. Again, we will measure something, but we don't know what behind that. That's very important. And when we want to measure alveolar recruitment, what we basically want to measure is that if we go from a PEEP low to a PEEP high, okay, we don't want to measure the increasing volume because distension, but we would like to get these alveoli that were closed and now are open. And it's not so easy. Now, the story of lung volumes and alveolar recruitment didn't start with lung volumes, but with pressure volume curves, actually. Because, my friend Marco Ranieri say, oh, because he saw 1991 on that picture, probably. Actually, pressure volume curves were very popular. How to measure recruitment with pressure volume curves? There was one problem, that we knew how to identify the pressure, but what is the volume to put the pressure volume curves on the same volume axis? Now, there was this idea that came from Katz, and then was developed actually from Ranieri and other Canadian groups. Okay, let's measure the volume, the PEEP volume. So at the end of expiration, you disconnect the ventilator, the patient expires to 0 PEEP. You can measure with just a spirometer the volume expired, okay? And you use that volume to build up your pressure volume curves. This is the PEEP volume, or some PEEP, 5, okay? Then the pressure volume curves. You do the same for the second curve. And you choose a pressure, was very popular 20, 18, 20, and the recruitment is the shift volume, the volume shift at the same pressure between the two curves, okay? This was recruitment, and many studies and many papers have used this system, and we have learned a lot from that. But I was not comfortable with one point, okay? That basically what you do is to assume that when you disconnect the ventilator from the PIP, okay, you lose all the alveoli you have recruited. And irrespective from the PIP you come, you go back to the same FRC, okay? I didn't like that point. So we did a study, and using the same assumption, other studies, this is a very popular study on stress and strain, they just measure one FRC to one condition and apply that same FRC to all other conditions. So we did a study. We disconnected the ventilator from the patient. We measured the PIP volume, and at the end, after 10 seconds of disconnection, we connected the bag with the helium, and we measured the FRC, okay, coming from different PIP, 5, 10, 15. And what we found was that there was a significant increase in FRC coming from different PIP level. Higher PIP level will end up with a higher FRC. And what was relevant for measuring the recruitment? Well, the dotted one is if we assume the same FRC. And this is if we use the correct FRC. And you see that there is a difference. And you can see here the difference between 10 and 5 of PIP or 15 and 5 of PIP. Okay? And for some patients, this difference is like more than 100% of difference. Okay. So you are telling us that we have to measure the FRC and ZIP, the volume PIP, and so on. Very difficult. It's not something that you can do at the bedside. But remember, we have a ventilator that allows us to measure end expiratory lung volume without disconnecting the patient. So in this study from the French group, from the De La Monica and a group from Washout, they measured the end expiratory lung volume with the ventilator during the PIP, okay? They also measured the PIP volume because it was part of the study. And then they did another thing. Let's try to have a system, a technique that does not require to disconnect the patients and just rely on end expiratory lung volume measure. That was they suggested this in another paper. Let me try to explain. This is basically what you can do at the bedside. Okay, you have a ventilator that gives you end expiratory lung volume. You are a PIP 6. You have end expiratory lung volume 1,000, 350, and you have this compliance. If you don't have any recruitment and you change the PIP, okay, you expect a change in volume due just to the compliance and the PIP change. So you will go up with, if you have 29 of compliance, you will end up with 174 of volume. And so the expected end expiratory lung volume is 1,524. You measure it, and you find out that is 1,950. Is much higher than you expected. So that's what we can call recruitment. That was the investigator suggested as recruitment. And they show that in doing in this way, this is the expected change in volume, and this is what they got. And you see that is higher. Higher the recruitment, higher the difference between the expected and the measured one. They found that this technique, using just the end expiratory lung volume measure and the compliance, correlated very well with the classical technique with pressure volume curves. So we have a system that you don't have to make a pressure volume curve, you have just to measure end expiratory lung volume. Now, one would say me, well, but why you have to measure the end expiratory lung volume? If I have a spirometer and a good ventilator, I can just measure the change between the 2 points, okay, the 2 PEEP, on inspiratory and expiratory volume, okay, and I have the same value. That's what Salvatore Maggiore and again the Brochard did in this study. They have a decremental PEEP level, and they just measure the change in and out of the volume to get how much volume was going out. And they build up the same technique with the pressure volume curves. Well, there is a problem. Let's say that you measure a recruitment with any technique. In one patient is 400 ml, in another one is 200 ml. You would say, well, the first one is recruited more than the second, okay? But then I tell you that the starting and expiratory lung volume was 2,000 for this one and 500 for this other patient, okay? Means that you have a recruitment of 20% on this patient, but 40% of this one. From my point of view, probably this patient will get a much, is a more recruiter, is a much higher recruiter than this one. This may explain why in the study I showed you before, okay, when we use relative changes in lung volumes, okay, we get a better correlation with gas exchange or respiratory mechanics than just using the absolute volume of recruitment that depends on the size of the patients, the compliance, and so on. So, just this study to remind that we don't want to use just one technique and hope that the technique will tell you everything, okay? It's very important to integrate any technique, ultrasound or with basic classical respiratory mechanics. In this study, we have compliance and expiratory lung volume, PaCO2 gas exchange, and dead space, which is one of the numbers I would like to have more often, but it's not always so easy. I go to my conclusion, starting with the premise that I already told you, that is any special technique must be integrative of a standard respiratory mechanics knowledge, okay? Always, you will rely always on that. It's feasible to measure lung volumes. Yes, it's feasible. We have, but you need the machine. I hope that more ventilator will try to have something similar. But the interpretation of the result is not so straightforward. It's straightforward if you do a recruitment maneuver. You have the same PEEP level, you measure the end expiratory lung volume, recruitment, you measure again the expiratory lung volume. If the expiratory lung volume is increased, you can say you have recruitment. How much, that is more difficult to interpret. Thank you.